All right. Probably going to give maybe another minute or so here before we get started. People kind of slowly trickling in. Before we get going though today, anybody want to fill me in on what you guys were talking about last week? If there were any particular questions, anything like that? Nobody? Michelle, how about you? You know what we're talking about.
SI joint.
Oh, very good.
I'm trying to
Very
remember what we went specifically over last time. I know we were talking about one of Lizzie's patients that we kind of incorporated in there.
okay. All right. Well, we're going to continue with the SI joint this week. There may be some overlap with some of the things that Dave was going over, and I think that's okay. Want to make sure that we're on the same page before we get into the on-site course. We'll go through kind of some of the function stuff, a little bit of the anatomy. And I do want to start, if I can get to it today, I want to start getting into a little bit of the sacral torsion discussion, um, just from, a terminology perspective, a naming perspective, kind of how functionally these things are supposed to occur. So we'll talk a little bit about that sort of stuff as we get into it. You guys may have to forgive me a little bit. I'm fighting off some sort of grunge too. So if I start coughing, forgive me. No questions? Nope. Okay. Well, I'm gonna pull up my stuff then. Guys out of the way. All right. Are you guys seeing my screen? Hopefully. Yeah. All right. Well, if you're not, somebody's gonna have to speak up. All right. So SI joint. For whatever reason, I think we generally we look at this thing as being a very difficult body region to talk about. Um, even as we start talking about it here, it's probably just because of the way it's put together. I mean, you can look at here on the very first sentence that we have up here, a paired synovial amphiarthrodal joint. That is a complete and utter contradiction in and of itself. Okay, synovial joints are typically very free moving. They have a lot of mobility a bit available to them, and then the amphiarthrodal joints are much tighter. They don't have a lot of mobility. They're more designed for stability. But this is kind of the nature of the sacroiliac joint in and of itself, is that it's kind of um, a contradiction, right? Half of the joint contains hyaline cartilage, so that's the sacral component. The other half, the innominate side, contains fibrocartilage. So again, we have kind of this half synovial mechanism, and then this half much more stable joint. It's been described as, kind of syndesmosis-like, not technically a syndesmosis, but it is held together um, by a lot of cartilage mechanisms, by the fibrocartilage. The interosseous ligament, which we'll talk about here in a few minutes, is very unique in its morphology. The only other ligament that's relatively like it in the body is the subclavicular ligament or the costoclavicular ligament. Um, and it's because of the morphology of it, where it's kind of this three-dimensional, almost cone shape. So it can kind of resist motion in every different direction. Okay, and that's why it's such a stable joint to begin with. And it kind of has to be, right? Because it's the connection of the lower extremity to the trunk, the spinal column, all these different things. It's kind of the platform on which pretty much everything that we do has to operate. If we don't have a stable articulation here, it's a tough sell, right? It's very difficult for the body to kind of deal with that sort of thing. So again, very much specialized for stability versus mobility, the ability of it to transfer load and weight between the trunk and the lower limbs, or between um, the the spine and then the periphery, right? And so that kind of sounds like the same sort of thing. But it's really not. It's more of a situation where we're able to do that both in a closed pack and a loose pack situation, where the lower extremity is mobile versus where the lower extremity is fixated. So both those two things have to be concurrently available via the sacroiliac joint. Motion, relatively minimal. Most um, what would you call it? Most literature would suggest that there's only between 2 and 4 degrees of actual movement there. It's relatively speaking more mobile than that, um, but there are a few caveats to it. So the idea is that because the joint actually it's actually kind of L-shaped like this. We have kind of these shifting movements that are able to occur there. But relatively speaking, the motion becomes much more minimal in a non-weight bearing position. Excuse me. And what does that mean? Basically, if we're not up and standing on on our feet, the joint is significantly more rigid. Okay, now why is that the case? Well, there's a few factors that play a role here. So number one, that fibrocartilaginous pad that's associated with this, it's relatively thin, but it actually has some compression available to it. And then that interosseous ligament has some very dense collagen to it. And I kind of think of it almost like a sponge sitting in between the two articular surfaces where if there's no weight going through this thing, right, and it's at its full thickness, relatively speaking, there's not going to be a lot of play between the fibers there. But as soon as we put weight through that, right, as soon as we put weight onto that mechanism, it compresses, those fibers slacken off, and now all of a sudden we have more motion that's available. So when we look at some of these studies that say, oh, it doesn't move at all, some of these studies say, oh, it moves very minimally. Excuse me. Um, a lot of these things are being done in non-weight bearing positions, right? And so when we're checking these sort of things, it's not necessarily indicative of the true function of the joint and what it's physically capable of. Okay, so that really has to be taken into consideration, and it will play a role, knowing that this joint is more mobile in weight bearing. This will play a role in the availability of movement with things like striding. Okay, and we'll see as we start to talk about it here in a little bit, the potential for these sacral torsions to occur is directly related to which leg is weight bearing, right? Which extremity is actually is supporting our body weight at that time. Okay, so very important to understand that. Um, but again, we have to take it kind of with a grain of salt because again, a lot of these studies that we're finding and some of the research that's been done on this stuff, it's not necessarily taking into account the functional aspect of this, and it's just looking, kind of purely at the anatomical and biomechanical components. All right. So articular surfaces here, and I kind of touched on it a little bit. The sacral surface, so this is the, kind of the lateral portion of the sacrum itself. Generally has kind of this ear-shaped morphology to it, and it's covered by a thicker component of hyaline cartilage. So much smoother cartilage, much more capable of producing some mobility. And some might suggest, okay, this is kind of that quote unquote synovial half of the joint, right? So um, as we age, this joint not only becomes um, deeper, but it also starts to develop these ridges and depressions, kind of these undulations of the surface that start to, essentially kind of stiffen the joint, right? It kind of makes the congruency of the two articular surfaces much more intense, right? If we start developing these little divots and all these little different ridges and whatnot in the articular surfaces, it's going to be harder to produce any kind of movement through that joint just because the articulation has become so specifically defined, right? But that does increase with age. And that's important to understand because as we talk about the idea of primary sacroiliac joint dysfunction, right? So primary meaning it happens without any external influence. One of the only caveats to that is children under the age of 12 or 13, something along those lines, right? So That age is about when we start to develop some of these ridges, some of the maturity of the joint starts to come into play, and so it starts to become much more stable on its own, right? Just from the actual articulations themselves. So, very important to understand that, because if we do have somebody that comes in that's a younger patient, we have to understand that they can have their own primary sacroiliac joint dysfunction. Okay. Iliac surface. So again, this is now the medial surface of the innominate. Also ear-shaped, relatively reciprocally, but not quite. It's a little bit deeper, um, but also now covered by fibrocartilage. Okay, so this is actually significantly thinner, which for whatever reason in my brain seems to kind of be a contradiction. Usually when I think of fibrocartilaginous pads, I tend to think of those things being much thicker and much more robust versus the hyaline cartilage. But in this sort of scenario, that's not what it is. Um, and again, these surfaces are reciprocal. Okay, so they do match up against each other, but they're not as congruent as what we would typically expect in a true synovial joint, right? So it's not the same as the articulations between the distal end of the femur and the tibial plateau, right? Those things should be much more congruent and allows for much more joint play. Okay, so again, reciprocal commitment, but incongruent, and that also helps to increase the stability through that interlocking. Okay, joint capsule. Um, Relatively speaking, this thing is not really there. There is some thin anteriorly oriented, so on the inside of the pelvic bowl, there is some joint capsular mechanism that's thickened by the anterior sacroiliac ligament, but generally it's much thinner. It's much more, um, it's much less present and much less consistent with producing stability. Now, posteriorly, the capsule is almost entirely absent. Okay, and it's really the stability of the joint is provided much more by the interosseous ligament, the reciprocal incongruency of the two joint surfaces, and then the posterior ligamentous system, which we'll talk about here in a minute. All right. Now, maybe this is something that Dave talked about. I went through some of his notes that he sent out last week. But force versus form closure, very important kind of topic that we have to discuss, right? And especially with the sacroiliac joint because of how stable it is supposed to be. All right, so force closure, it's exactly what it sounds like. We're exerting a force to produce stability, right? So it's achieved through the muscular interactions, primarily in this situation via the posterior sling mechanism. So this will be the posterior lateral sling system as well as the deep longitudinal sling system. Sorry, guys. I'll get through it one of these days. Um, so the posterior lateral sling, essentially that's the congruency between the lats and then the contralateral glutes, okay, interconnected via the um, thoracolumbar fascia. Okay, so all these fibers, as we're looking at these things, as they crisscross the pelvic region, essentially what they do is they create kind of this nice compressive force going across the SI joint, right? So there's not a lot of muscular mechanisms that go directly across the sacroiliac joint itself. Um, because obviously this posterolateral sling system, it's much more superficial than that. It's a global system designed to help, functional movements from the upper extremity as far up as the shoulder, all the way down to the posterior knee. And if you want to consider kind of the interaction between the well, so I'll just explain what it is. So the lats, they attach to the medial bicipital groove on the humerus, right? And they come all the way across the back, attached to the thoracolumbar fascia that crisscrosses then the pelvic mechanism, and then the superficial fibers of the gluteus maximus, right? So this will cross the hip and attach into the IT band. Okay, IT band goes down the lateral side of the leg and attaches to the tibia and then also to the fibular head, right? And so when we have that, there's a continuation then from the fibular head all the way down going down to the via the peroneals under the foot until it attaches to that tubercle on the medial side of the foot between the navicular and the medial cuneiform, right? So really a very long sling mechanism that connects everything from the shoulder all the way down to some of the tarsal bones in the foot. So really important. Um, and again, we'll talk more about how we can use these things potentially for stability training, functional training, all these different things as we go along. And we'll definitely cover it during the course. Okay, the deep longitudinal sling. This is going to be some of the long paraspinal musculature, including the multifidi. So this would include things like the semispinalis, longissimus, and iliacostalis. Iliacostalis potentially being one of the most important versions of this because of its interaction with the ribs themselves. And then deeper as well with the different layers of the multifidi. And then there's a connection there as it comes down and attaches to the PSIS via the posterior sacroiliac ligaments, the sacrotuberous ligament, and then that attachment on the ischial tuberosity to the hamstrings, and in particular, the biceps femoris. Okay, and again, that biceps femoris comes all the way down and attaches to the posterior elements of the fibular head. And then again, we have that same peroneal mechanism that's going to wrap underneath the foot here, right? So again, these are more superficial. They're not necessarily directly interacting with the joint as we usually see things. It's not like the rotator cuff being able to particularly rotate the glenohumeral joint, things of that sort of nature. It's really controlling things by controlling position of the innominate and then, via some of the interconnections there with the ligamentous system, the position of the sacrum within the pelvic bowl. Okay, and I'm going to talk a bit more about that as we go. Um, Form closure is realistically it's the articular stability of the joint, right? So this is achieved through close packing the joint, which in this case is done by producing a sacral nutation. So tilting the superior portion of the sacral base in between the innominates. Okay, so what that means is if the SI joint is taken out of this position, right? So if all of a sudden we have an innominate that is anteriorly rotated relative to the sacrum, right? So if we have an anterior innominate rotation, this is what we call a quote unquote unlocked sacroiliac joint. Okay, this is a term that's used by Diane Lee in a lot of her research and a lot of her teachings um, to basically to describe a sacroiliac joint that's more vulnerable to external forces. Okay, so what this means is if this is my sacrum here, and you're looking at the front of it, and my innominate sits here, right? And I all of a sudden have this innominate tilt forward. Relatively speaking, that same side, that ipsilateral sacral base, has come posteriorly. So it is quote unquote counter nutated. That's going to quote unquote unlock that sacroiliac joint. And now all of a sudden we have the potential, and again, I can't stress the word potential enough, but we have the potential for some vertical shearing to occur between the sacrum and the innominate. Okay, the joint itself is very stable. We've been talking about the articulations themselves. There's a lot of ligaments, a lot of muscular tissue, all these different things helping to hold this thing together. But realistically, this joint should be able to lock itself up very comfortably with this form closure, right? And so over time, if we have a situation where an SI joint is consistently unlocked and the patient is continuing to put themselves into weight-bearing situations, striding, standing, going up and down stairs, all these different things, um, eventually this will start to break down some of these tissues, right? And some of the most common tissues that will become painful are the long and short dorsal ligaments, things of that sort of nature. Occasionally it'll be the sacrotuberous ligament. Um, a lot of these things play into the role, right? And so we should be able to find this um, just with simple palpation. Okay, so well, what does that mean? Basically, if we think of a Fortin's point test, right? So it's one of the most reliable tests that we have for quote unquote SI joint pain is the patient walks in the door and they say, yeah, it hurts right over Fortin's point, kind of near that PSIS, and that's a pretty good indication that there's some sacroiliac joint pain being associated with their complaints. We have there's actually technically two types of Fortin's point testing. Number one is a subjective version, which is where the patient tells you it hurts right there and they point to it. And number two is an objective version, where we actually palpate across that joint line and it reproduces the discomfort that they're complaining of. Okay, that's an quote unquote objective version of this. Um, there is a scenario, and I'll briefly touch on it, where we can have a positive subjective Fortin's point, but a negative objective Fortin's point. Okay, so what does that mean? It means that when we palpate it, it doesn't reproduce pain. Why? Well, odds are it's one of the structures that's too deep for us to get our finger on, right? So, for instance, that interosseous ligament, it's too deep, too much overlying tissue, can't get our finger on that, right? Because it's in between the two articular surfaces. That's a possibility. Probably the more common situation is that it's actually not it's not any of the external structures. It's an internal structure. So this would be more likely to be um, like a pelvic floor pain, right? So more of a muscular discomfort um, due to pelvic floor dysfunction. And again, in most cases, in patients that are, what we would consider healthy adults that aren't within our typical risk factor group for primary SI joint dysfunction, we're still looking at some sort of pelvic obliquity that's created this pelvic floor dysfunction, right? And so that still means correcting the obliquity, which might mean mobilization of the SI joint, might mean manipulation of the SI joint, but then it's also very likely going to require some sort of treatment elsewhere. Treating a thoracic ring lesion, RING lesion, for instance, or treating a Eufer lesion, or maybe treating a an old chronic lumbar pathology, something of that sort of nature, right? So, but that's a very common profile where we can have the positive subjective, but a negative objective Fortin's point. Any questions about any of that before I push on here? Nope. All right. Let's keep going before my voice completely fails me. All right. This might be a little difficult to see, but this is kind of a description of some of the ligament structure here. Um, Relatively speaking, you're going to find better pictures than this, but it's a decent outline of the way these things look. So the ventral sacroiliac ligaments, realistically, this is just a thickening of that very thin anterior joint capsule. Okay, so we're talking about right through here on the anterior surface. Um, Not necessarily producing a lot of stability here, but it is possible to damage these ligaments. Um, and what this tends to recreate, excuse me, is more anterior pain, right? Because these structures here are supplied more by L1, L2, maybe a little bit of L3. And so you're going to get more things like groin pain, anterior hip pain, or maybe like medial thigh pain, things of that sort of nature when these things are damaged. The interosseous ligament, I've been talking about it quite a bit, but this is the strongest ligament in the entire body, maybe rivaled only by the transverse ligament in the OA in the AA region, right? So completely fills the space between the lateral sacral crest and the iliac tuberosity, right? So we're just dealing with the two surfaces there. It completely fills that inner space. Again, those fibers are multi-directional, and basically what they do is they spiral around each other. Again, to kind of create this conical type of shape. Um, and again, it is one of those structures that will become compressed with weight bearing to help slacken off some of those fibers and allow a little more motion through the SI joint with things like striding. Okay, so again, we'll talk more about striding and sacral torsions here in a few minutes. Um, the long dorsal ligament, long and short dorsal ligaments. Relatively speaking, they follow the same path. The short just attaches a little more laterally as far as on the sacrum goes. So these things in general are going to resist counter nutation. They're pretty much the only ligaments that are designed to do that. So if you look at it here, it comes down from kind of the medial side of the PSIS and this iliac crest here down to kind of the lateral components of the sacrum, right? So what that does is if that sacrum starts to counter nutate and that relatively that PSIS starts to elevate, it's going to resist that sort of moment. The sacrotuberous ligament, here we're looking at it from this perspective. The ischial tuberosity is here. Sorry. And realistically, this thing kind of overlies the entirety of that ischial tuberosity. And basically, this ligament is just a continuation of the tendon of the hamstring muscles. Okay, so in particular, the biceps femoris. Um, or you could think about it the other way, where the ligament is a continuation of the tendon, or the tendon is a continuation of the ligament. Kind of depends on how you're judging the orientation there. But this ligament is going to be more designed to resist nutation. So again, when the joint is in a quote unquote closed pack position, and that sacrum is tilted anteriorly, that sacral base is tilted anteriorly into the pelvic bowl, we're going to have tension on this sacrotuberous ligament. Okay, so again, it's going to make it much more stable in that sort of position. The sacrospinous ligament, same sort of idea here. We have the sacral spine, or sorry, we have the ischial spine here. And again, same sort of idea. This is going to be tensioned by nutation. So again, a secondary thing that's going to be tensioned and help to produce stability in a nutated position. The interosseous ligament also tensioned during nutation. So again, it very much lends credence to the idea that this nutated position of the sacrum within the pelvic bowl is the quote unquote closed pack position of the joint, and that's where we're going to get the most form closure and stability out of that mechanism. Okay, so ILL is the iliolumbar ligament. Multiple bands here that attach both anteriorly and inferiorly. A lot of them will connect to the transverse process of L5. I believe it's about 40% of the time. I'm, don't quote me on that number, but there's also a band that will go up to the transverse process of L4 to help produce anterior stability. So again, this is just another mechanism by which we help to stabilize this lumbosacral junction. Now, the um, iliolumbar ligament begins life embryologically as a part of the multifidi musculature. Okay, and because of the way that humans develop, it actually is embryologically originated through the L2 spinal segment. Okay, even though it's all the way down at L4, L5, S1, um, embryologically it originates from L2. And so what this means is we can damage the iliolumbar ligament providing producing some instability here. But what it's going to more likely do as far as pain reproduction is it's going to give us anterior hip pain or groin pain as a result of that. Okay, so there are bands of this that are palpable um, just by deep digital palpation. Um, Most likely, if you go right off of the medial edge of the PSIS and just try and sink in as deep as you can, you're going to be able to get a portion of the superior bands there that attach to L5, or maybe if it's a variation, the ones that attach to L4. So that should, if being said, if we're able to palpate that, um, reproduce the pain that the patient is complaining of, right? So if they come in complaining of groin pain, if we can get our fingers on that, it should reproduce that groin pain after a period of stress, right? We always want to think about referred pains like this. So anterior groin pain would be a referred pain because it's not directly over the structure. A lot of times those things take either sustained or repetitive stress to start referring pain into that distal or non-associated body region, right? So that sort of stuff we have to take into consideration here. But if they come in and they've been walking, and it's already uncomfortable, and you put some palpatory pressure on this structure, it's very likely going to reproduce the pain that they're dealing with. Okay, a lot of ligament stuff here, a lot of stuff to think about, but realistically not terribly complicated, I don't think. And we don't have to really worry about stressing most of these tissues. We can palpate a lot of these, sacrotuberous, sacrospinous, long and short. We can get our fingers on all those. The iliolumbar ligament. Realistically, the only ones that we're not going to be able to get our fingers on to um, attempt to reproduce discomfort is the ventral ligaments and then that interosseous ligament. Okay. All right. Here we are. Sacral torsions. If you feel like you need to take a quick shot of Hennigan's or something like that to get yourself prepared for this, go right ahead. Um, I'm going to try and make it as not painful as is humanly possible. Okay. But realistically, this is a complicated subject. Okay. And a lot of it has to do just with the terminology that's associated with these things. Okay. So I'll jump right down to the bottom here to talk about that. So sacral torsions. How we name these things is we first name them based on the direction that the front of the sacrum ends up facing. Okay. Secondarily, we name it based on the axis on which it is moving. Okay. So a right on left sacral torsion suggests that the sacrum is facing to the right, but it's moving on a left oblique axis. Okay, so let me show you what this looks like here. Left oblique axis means that the axis is going through the superior portion, so the sacral base on the left side, and then it comes down and it exits via the ILA on the contralateral side. Okay, so if this is the sacrum, it looks like we're going in through this point at one on the top side and out through this point. And so what we're getting is kind of these oblique movements of the sacrum relative to the innominate around it. Okay. So again, naming that suggests a right on left sacral torsion means it's facing to the right, but moving on the left oblique axis. Okay. But if you guys want me to show you, this is probably easier to see. So left sacral base up here where my finger is, right ILA, right? So this is the left oblique axis. It's facing to the right, but it's moving on an axis between these 2 points, right? On the left oblique axis. Again, I don't expect you to understand and be, a savant about how that works right off the bat. But just so you know, that's the terminology of it. And I do think that's one of the complicating factors here. All right. So what are these things? What use are they? Why do we have to deal with them in the first place? Well, these things are creating either with striding during gait or with some sort of body rotation, right? So twisting of the trunk. Okay. Sorry. So we have to take into account that during striding, they're asymmetrical, right? So the um, torsions that occur there are asymmetrical because we have one leg going forward, one leg going back. With body torque, our feet are fixed and we're twisting around things. So now we're going around a vertical axis, and so that's a different sort of story. And we'll talk a little bit more about that as we go. Um, so again, the axis here is between the sacral base on one side and the opposite ILA. Okay, so this is what our oblique axis is determined by. And again, the axis itself, what axis we're using, are we using the left or are we using the right? It's determined by the weight-bearing leg. Okay, so like I mentioned previously, the SI joint that is weight bearing is going to be significantly more mobile than the one that is non-weight bearing, right? So if I am in left stride stance, right? So if I'm in mid stance on my left leg and my right leg is in swing through phase, I'm going to be functioning off of my left oblique axis at that point, okay? Because my left leg is the one that's weight bearing. All right. Are we okay so far? Do you need me to repeat any of that, Courtney? No, you like me to repeat things?
Yeah. Can you repeat again?
Yeah, yeah, I can. All right, so again, striding is really where these things become the most significant, right? So body torque's a separate situation, but we do get, reciprocal movements that occur there. Um, the axis that we're moving off of goes from superiorly at the sacral base across inferiorly to the contralateral ILA. Okay, and again, sometimes the phone is a good way of looking at this. If that's my here to here, if that's my oblique axis, then my motions are going to be here and here, right? So this sacral base is going to be mobile, it's going to be moving. This ILA is going to be mobile, it's going to be moving. But we're pivoting around this orientation, okay? The axis that is functional, the one that is working, okay, that is mobile, is determined by the weight-bearing leg. Okay, so again, if I am in left stance phase, right, my left leg is in mid stance, my right leg is in the middle of swing through, I'm functioning on my left oblique axis because that's the weight-bearing leg. Okay. As far as naming these things, we'll start talking about this. It's really a good idea to start just thinking functionally of which direction is the front of my sacrum going to be facing. So I'm going to say, okay, it's facing right. That's a right on left oblique axis movement, right? So I'll talk more about how we name these as we go through and we start doing some examples and things like that. So a right on left would be a backward sacral torsion, just to make things more complicated. The idea being if I'm on a, well, I'm not going to show you the picture there, but if we're on a left oblique axis like this, what's happened here is that's facing to the right. The sacral base has moved backward. So it's a right on left backward sacral torsion. Then again, we'll go through hordes of examples of these things, especially during the course, um, the on-site course. So we'll make sure that you guys understand the terminology. And we'll talk through it. We'll have you guys go through your own examples, all kinds of stuff like that. But the terminology, again, I think is one of those things that really can get people's heads spinning about it. So don't feel like you have to be an expert on it right away. I don't expect you to. In fact, if you were, I'd be very impressed because it just doesn't happen very often, right? So we'll keep working through it as we go. Okay, again, here's our image. Um, this being our oblique axis going around this way. So left on left would mean that this right side sacral base would come forward, relatively making the sacrum face to the left on the left oblique axis. So that'd be a left on left torsion. If the sacral base goes posteriorly, then all of a sudden the sacrum is facing to the right on the left oblique axis. So we have a right on left torsion. Oh, it's a big lot of words. All right, striding. Here we go. This is where it really becomes important and why it becomes problematic in general. Okay, so striding. If we take the example that I was giving you previously, the patient is in left mid stance. Okay, so my left foot is down on the ground and my right leg is in the middle of swing phase. Okay, again, this is going to put the motion occurring around the left oblique axis because my left leg is weight bearing. Okay. That relatively means that the right SI joint is tighter. It's not moving as much. So as that right leg moves forward, swings through toward heel strike, what we're going to get is we're going to get some stiffening of the posterior hip structures, the right innominate bone, is going to be pulled into a posterior rotation, right? Or sacral flexion, however you want to look at that. Um, and because that SI joint is non-weight bearing and therefore less mobile, it's going to move the right sacral base posteriorly with the PSIS. Okay, so again, we're here on our left oblique axis. This right leg is coming through towards heel strike. The innominate is rotating posteriorly. And so what that's going to do is it's going to take the sacral base posteriorly with it, creating a right on left backward sacral torsion. Okay. Once we heel strike on that right side, the axes begin to change. Okay. There's a brief moment where both legs are weight bearing, where we're at heel strike before we go to heel rise on the left side. There's an extension moment occurring on the left side and through the left hip, which will create some tension through the left psoas major. Okay. The psoas then is going to create an ipsilateral side bending, extension, and contralateral rotation of the lumbar spine. Okay, this is our quote unquote latection moment coming from below. Okay, we've talked about this through the TL junction and the function of the lumbar spine as far as its movement capabilities, functional couplings of movement, right? So again, we're going to get extension, ipsilateral side bending, and contralateral rotation. That is produced via the tension into hip extension on the psoas major, right? Remembering the attachment points of the psoas. It attaches to the anterior portion of the vertebral body as well as the anterior portions of the transverse processes. So if we have our transverse processes out like this, attaching here, it's going to pull it forward for extension, tip it this way for ipsilateral side bending, and pull that forward for contralateral rotation. Okay, that should be, hopefully we've mentioned that enough times now that it's getting to sound a little familiar. Um, then, as the weight starts to transfer over to the right leg, right? So now we're starting to go into heel rise on the left side. This overall, this is a scoliotic effect, right? Via the psoas major, right? On the lumbar spine. Along with the continued extension of the left innominate, right? So that's the anterior rotation of the left innominate. We suddenly switch the torsion to the right axis. Okay. Difficult to comprehend. I get it, right? So we were in this position where we're here in a right on left. What's going to happen then is we're going to switch to the right axis. But now we're still facing right, but now the axis is going through the right side. So now we have a right on right forward sacral torsion. Okay. Again, we'll keep talking about it as we go. Toe off on the left side releases this anterior torsion and adds energy into the stride. Okay. This is occurring through the tension on the psoas, through the tension on the sacroiliac ligaments, all of these different structures, the anterior hip capsule, anterior femoral fascia, all these different structures, the IT band, et cetera, et cetera. All these different things get stretched out and tensioned as we get to that point. And as we go to toe off, all of those things start to recoil, right? All of that elasticity starts to recoil. It adds energy into that spinal engine, right? Because now we're moving the psoas, or sorry, we're moving the sacrum via the psoas. Okay, so very efficient, very effective method by which we're able to produce passive energy to help us become much more efficient at striding, right? Remember, we talked about some of the three things that humans have that no other, upright ambulatory mammals have, right? We have the ability to produce a lumbar lordosis, a hip that extends beyond neutral, and the Q angle of the femoral neck, right? So All of these things help to produce this tension, right? These coiling mechanisms, and then that mechanism gets released, and so it adds energy back into the system. So again, this scoliotic mechanism here that's created via the tension on the psoas, via the torsions through the sacrum, these things very much help to torsion the trunk. And again, same sort of idea. It just releases that energy into the system, makes us very efficient. Okay. And then it helps us really um, in quiet striding, comfortable striding, to be, very minimalist as far as the amount of energy that we have to expend in order to keep us moving. Okay. I'm certain there's going to be confusion there, but we're going to keep pressing on here. Okay. Um, Assessment of sacral torsions, kind of hard to do, to be honest. The idea is that a sacral torsion, when you look at it, the first thing that most people are going to want to look for is positional alterations. Okay. Is this sacral base farther back than the other? Is this ILA farther back than the other? Well, here's the problem with that. Um, if I go to look at that and say I have a right on left sacral torsion, right? So my sacral base has come posteriorly, my ILA has gone anteriorly. If I look at that, the entire right side is going to look further back, right? It's going to look like it just did this and turned to the right, right? And that doesn't tell me if the sacral base came back on the right side, if the ILA went forward on the left side, or if the sacral base went forward on the left side, or the ILA went backward on the right side. It doesn't tell me which is which, right? It just tells me, yeah, it's facing to the right. That's all it says. So positionally, we're not really going to be able to use that. Okay, it's just not going to give us enough information, and odds are it's just going to end up confusing us when we have to do our actual biomechanical testing. Okay, so what we have to do with this is we have to look at the loss of motion that occurs with our SI joint passive mobility tests. Okay. And again, we'll talk about these during the class. Um, Really easy to do. You lay somebody down flat on their back, you fixate one side of the pelvis, you move the other side, you push one side posteriorly, you push the other side anteriorly. We're just checking to see if it moves, right? Is there some pliability there? Is there some, or is there some restriction, right? So, but then we have to correlate that with what could have happened to the sacrum. Okay. And again, I want you guys to understand this. This is relatively a sacroiliac dysfunction, meaning the sacrum has moved relative to the innominate, right? Versus an iliosacral dysfunction, where the innominate has moved around the sacrum. Okay. These are relative terms, right? So the sacrum doing this is a sacroiliac dysfunction where we get a torsion, whereas the innominate doing that is an iliosacral dysfunction. Okay. So we have to kind of look at that from that perspective, right? So if I have a situation where the right sacral base has come posteriorly, relatively, that means the innominate is actually anterior compared to the sacral base. So I would have an inability to produce a posterior rotation of the innominate on that side, right? If the sacral base has gone anteriorly, relatively speaking, the innominate is posterior to that, so would have a difficult time going anterior, or my mobility test would feel stiff going anterior. Again, it sounds like a lot of words, and it is, believe me. We'll continue to talk about it. I just want you guys to have kind of a base knowledge set here and terminology understanding of what's creating this sort of stuff. Okay. And it is possible, and I used to believe this very strongly, that sacral torsions are more easily appreciated in prone. Um, I believe it less now than I did a couple years ago. But I'll show you how to do both tests when we get to the course. I think you can kind of do it either way. In fact, I've started doing a lot of mobility testing and side lying with more of like a quote unquote gapping type of technique. And again, I'll show you that when we get to the course. Um, because at that point you're already in a position where you're able to treat it. So again, we'll talk more about that as we get to it. All right, so we talked about this previously as far as causes of SI joint dysfunction, right? And what I was telling you guys is that even though that there's always the possibility for some sort of outlier or some sort of exception to the rule, um, generally I tend to think that innominate rotations or iliosacral dysfunctions are more likely caused by thoracic lesions coming from above or peripheral lesions coming from below. So thoracic issues, ring lesions, rib lesions, facet dysfunctions, or hip, foot, ankle type issues are more likely to create iliosacral problems, okay, where it's moved the innominate relative to the sacrum, okay? That's my opinion of things. I have been practicing that way for a decade or more, and it's never steered me wrong, okay? Sacroiliac lesions or sacral torsions, being the prime example of that, tend to be more likely to be caused by lumbar spine problems. Okay. This is more likely because of the inevitable motor pattern imbalances that we get with lumbar spine problems, right? So as major tone changes, short hip external rotator hypotonicity or inhibition, things of that sort of nature. All these different things, they tend to make me think that the sacrum's going to end up being kind of twisted into a funky position versus it being a true innominate rotation, right? So, and if we think about it from that, yeah, and Dave saying the same idea, right? So the idea here is that if we look at the sacrum as just another vertebra, right? Multiple fused vertebra, but it functions like a vertebra. That means vertebral problems, lumbar spine problems, are more likely to cause vertebral problems going down into the sacrum, right? Versus the innominate, we have to look at that as a peripheral bone, right? So it's functioning more in the periphery, quote unquote, as a peripheral bone. It's going to be more likely to be affected by the periphery, right? Hip, foot, ankle, or potentially some of the muscular interactions that are associated with the rib cage itself, right? And again, that's most likely to be the iliocostalis in most situations, right? It's just the most likely culprit in that sort of scenario. So, um, hopefully that kind of frees your guys' mind up about it a little bit. If you're looking at it and you say, I have an SI joint problem, I did my Portland test, I've got dysfunction here. Now I need to know what caused the SI joint problem. Well, now we're just doing screening tests. Seated rotation, I look at it and I say, ooh, yeah, they don't turn very well going to that same side. Odds are there's a thoracic issue there that I need to address. That's probably helping to contribute to the SI joint issue, right? Seated rotation is clean, but my hip quadrants suddenly look dysfunctional. Odds are it's a hip problem, right? Could be a EUFR, could be an arthrosis, could be a labral pathology, any of those sort of things. If those two things are clean and I look at my active passive resisted testing of the ankle and suddenly I'm lacking dorsiflexion, well, at that point, now I'm feeling pretty comfortable saying that maybe it's an ankle issue, right? So, um, again, the idea here is to just kind of use these quick screening tests so that we can narrow in on the other body regions that we have to do a deeper dive on. All right. I think that's probably all I wanted to get to today. So I think we're in good shape here. Pretty good timing. Questions, concerns, other than feeling completely overwhelmed by the terminology of it all.
Hey Eric, on the
Yep.
slides with the all the ligaments, we were missing a couple of those slides in the middle there. So we have the sacral torsions and we have the locking, but in between those, we were missing the ligament slides and the sacral introduction.
Oh yeah, yeah. Well, I just added that in this morning, so that's probably why. I'll get the new version sent over to Dave, and we'll get it straightened out.
Thank you.
Yeah, I wanted to make sure that I still had a little bit of stuff to talk about as far as just the anatomy stuff. I know it looked like Dave had gone through some of that stuff last week, um, but I wanted to make sure that we were all on the same page from a terminology perspective as we go with that. But yeah, I knew that was going to be the case, so we'll get that sorted. Other questions, concerns? Coming up quick here, I think, right, guys? I think it's 2 weeks away now, something like that.
19th.
Yeah, so 2 weeks. Cool. All right. I will I will be back next week. We can kind of go over either some case stuff, or if Dave has something that he wants to, some material that he wants to cover, we can do that sort of thing, or we can review some of the torsion stuff if you want.
Yeah, maybe a little case stuff. We could kind of roll some of the torsions in there. I know they're hard to kind of wrap their head around, so it's always a good thing to kind of, kind of walk through.
Yeah, and it's easier for me to describe them when I'm in the room with you guys because I can show you my position, like put myself in a stride position and kind of show you what my sacrum should be doing in those sort of scenarios. Um, so we'll go over it again. We'll go over it multiple times before the end of the weekend. So the idea here is just get it introduced so you guys can start kind of noodling with it a little bit. And then, yeah, hopefully by the time the weekend is over, by the time the on-site intensive is over, we're feeling a little more comfortable about it, feeling pretty good. And realistically, guys, most of the situations when you find these issues, the treatment's going to end up being the same. We're going to do some kind of manipulation or some sort of mobilization, um, because the grand scheme of things is we have to find the reason that it became dysfunctional in the first place, right? And that's going to be our thoracic issues or our hip issues or our lumbar problems and so on and so forth. So those things, the function of figuring out the torsions and anominate rotations and all that stuff, it becomes less and less important, assuming you can figure out what the reason was that it got there in the first place. All right. I will catch up with you guys next week then.